Great, thank you.
Okay, if you're ready, should we?
Yeah, sure. So let me just share my screen to get the slides up. Cool. So, good morning, everybody. My name is Manu. I'm an F1 doctor at Peterborough City Hospital, currently enjoying my rotation in psychiatry at the Cavell Centre. Thank you all for welcoming me here today to speak with you about diabetes and mental health. Please let me know if you can't hear me clearly or if my screen happens to freeze at any point so I can fix that. And also throughout the session, please note down any questions that come to you because there will be some time at the end for you to ask away. So let's get to it. Diabetes is one of the most common illnesses, and I'm sure you bright minds have covered it many times before. Today, we develop your understanding by exploring what you need to consider when approaching diabetes in psychiatric patients. Let's jump straight in with the learning outcomes of today's bite-sized teaching session. So the first objective is to understand the implications of diabetes to the psychiatric population, and then to understand how psychotropics affect diabetes, psychotropics being any drugs that affect a person's mental state. These two learning objectives are highlighted in orange with the orange circle next to them because going forwards, all the content that you see appear in orange will directly relate to the significance of diabetes in psychiatric patients. The rest are more generally related to diabetes and include to take a diabetes-focused history from psychiatric patients, to perform a diabetes-focused examination in psychiatric patients, to investigate diabetes in psychiatric patients, and to manage diabetes in psychiatric patients. So, what is diabetes again? Diabetes is short for diabetes mellitus, and it is an umbrella term describing a group of metabolic disorders characterized by high blood glucose. Diabetes is associated with relative or total impairment in pancreatic insulin secretion with varying degrees of peripheral insulin resistance. It is a major risk factor for both microvascular disease, such as retinopathy, nephropathy, and neuropathy, and for macrovascular disease, such as coronary heart disease, peripheral arterial disease, and stroke. As I'm sure you all know, the most common types of diabetes are type 1 and type 2, but we'll first talk about type 1 diabetes and its challenges in psychiatric patients. Then the rest of the session will be focused on type 2 diabetes. So type 1 diabetes is characterized by the autoimmune destruction of pancreatic beta cells, leading to a total impairment of insulin secretion. As such, patients require immediate insulin therapy. In the psychiatric population, type 1 diabetes can pose various therapeutic challenges. Firstly, patients with chaotic behavior due to cognitive or negative symptoms of schizophrenia use insulin erratically. When they do use insulin erratically, this can predispose them to hypoglycemic episodes or diabetic ketoacidosis with associated acute risk to life, or chronic hypoglycemia with associated comorbidity and premature mortality. Secondly, insulin at higher doses is lethal, and this needs to be considered in patients at risk of deliberate self-harm. Lastly, diabulimia is an eating disorder in which people with type 1 diabetes deliberately give themselves less insulin than they need for the purpose of weight loss, and also needs to be considered in a population at high risk of any eating disorders. Hopefully that gives you a little flavor of the importance of managing diabetes carefully in psychiatric patients. Now let's move on to type 2 diabetes, which is the most common type in adults and is most strongly linked with mental health issues. Type 2 diabetes is characterized by a combination of peripheral insulin resistance and inadequate insulin secretion by pancreatic beta cells. People with severe mental illness are twice as likely to develop type 2 diabetes compared with the general population, with prevalence estimated at around 11%. Additionally, approximately 3 in 5 people with diabetes report low mood as a consequence of their condition. And lastly, people with severe mental illness and type 2 diabetes receive poorer quality of diabetes management compared to people with mental illness, compared to people without mental illness. Therefore, patients are a high-risk population for diabetes, and therefore psychiatric patients require a special focus on their diabetic care. Schizophrenia is a psychiatric illness that has proven links with diabetes. And this is an example of a condition particularly affected because the prevalence of diabetes is 2 to 5 times higher in people with schizophrenia than in the general population. And this is largely due to a greater number of risk factors. People with schizophrenia are more likely to have obesity, hypertension, they're more likely to smoke, have a poor diet, a sedentary lifestyle, and have a genetic predisposition to impaired glucose tolerance. That's because studies have shown that people with genetic predispositions to schizophrenia also happen to have higher prevalence of the genes that predispose to diabetes. So there seems to be a genetic link there as well. Overall, this means that morbidity and mortality from cardiovascular disease are higher in people with schizophrenia than in the general population, again, pointing to how high risk this population is and therefore in need of special attention when it comes to their diabetic management. Another reason that people with schizophrenia suffer with high rates of diabetes is that antipsychotics, the majority of the medication they take, are also strongly linked to diabetes. It's first useful to remind ourselves of the side effects of antipsychotics, which include weight gain, dyslipidemia, increases in plasma glucose, and diabetes. And these side effects clearly affect a person's predisposition to diabetes. But to complete the general list of side effects, antipsychotics may also cause hyperprolactinemia, hip fractures, sexual dysfunction, extrapyramidal side effects, including neuroleptic malignant syndrome, anticholinergic effects, venous thromboembolism, sedation, and postural hypertension. The exact profile of side effects is drug specific, but this is still a useful list to be aware of for any exams that medical students may take. Now, let's dig deeper into how antipsychotic medications increase the risk of diabetes. The mechanisms involved are multifactorial and unclear, but may include 5-HT2A antagonism, which is a serotonin receptor, and this antagonism reduces the insulin sensitivity and therefore impairs glucose uptake in tissues around the body. The increase of free fatty acids also reduces insulin sensitivity and impairs glucose uptake. And antipsychotics also cause weight gain, which can reduce insulin sensitivity by causing metabolic syndrome. This again impairs glucose uptake in tissues around the body. Antipsychotics also cause 5-HT2C antagonism, another type of serotonin receptor, which interferes with the action of leptin, which is a hormone that inhibits appetite, affecting diet and thereby the risk of diabetes. Lastly, antipsychotics can cause damage to the beta cells in the pancreas by dysregulating certain transcription factors and by increasing lipids in the blood. Now, that was, of course, a very quick high-level summary of the mechanisms, and the finer detail can be found in the paper's reference at the bottom, but the high-level points are highlighted there in orange. Antipsychotics reduce insulin sensitivity, cause leptin resistance, and impair the body's response to glucose. It's useful to know that clozapine and olanzapine are most linked with diabetes and so require extra special attention when prescribed. These are second-generation antipsychotics, also called atypical antipsychotics, which tend to have worse effects on diabetes than first-generation or typical antipsychotics. Solutions to the risk of antipsychotic-related diabetes include monotherapy, only giving one antipsychotic at a time, because combining antipsychotics increases the likelihood of adverse effects, and choosing antipsychotics that have been proven to not increase the risk of diabetes. Aripiprazole is the most commonly used drug out of these, so if you remember just one, I'll go with that. But amisulpride and lurasidone also are relatively safe to give in patients at risk or diagnosed with diabetes. There's also an established link between diabetes and depression. Depression is twice as prevalent in people with diabetes than in the general population. And the reason is thought to be because depression has a negative impact on metabolic control, and likewise, poor metabolic control worsens depression. Like antipsychotics, antidepressants can exert effects on glucose homeostasis and weight. To start on a more positive note, however, selective serotonin reuptake inhibitors are indicated to have a favorable effect on diabetes, and so they are actually recommended as the first-line option. Serotonin and norepinephrine reuptake inhibitors do not appear to disrupt the glycemic control, and so are likely to be safe as well. However, tricyclic antidepressants are associated with increased appetite, weight gain, and hyperglycemia, so are best to avoid. Irreversible monoamine oxidase inhibitors also have a tendency to cause extreme hypoglycemic episodes, and so should be avoided in psychiatric patients with diabetes or pre-diabetes. Let's now discuss how to take a diabetes-focused history in psychiatric patients, starting with the history of presenting complaint. The classical symptoms of raised blood glucose to make sure you ask about are polydipsia, feeling extra thirsty, polyuria, needing to pee a lot, and blurred vision, as well as weight loss. However, most patients are actually asymptomatic, which is why the investigations are very important. But before we get there, let's discuss the symptoms of diabetic complications that can't be missed. Visual symptoms of retinopathy, such as blurred vision, floaters, and the progressive loss of visual acuity. Sensory or motor symptoms of a peripheral neuropathy, typically symmetrical and distal, such as numbness or the reduced ability to feel pain and temperature in the fingers and toes. The passing of foamy urine, proteinuria of nephropathy can cause this. Acanthosis nigricans, which is a dark velvety discoloration of the body fold, increases. Frequent infections, particularly candidiasis, UTIs, and abscesses. And lastly, impotence. So, in the past medical history, it is important to ask about socio-demographic factors that predispose to type 2 diabetes, such as advancing age and ethnicity, particularly South Asian, Hispanic, or Afro-Caribbean descent. Obesity and increased waist circumference are also important risk factors to check. And you'll also need to check for any comorbid cardiovascular disease and metabolic disease, such as hypertension or hypercholesterolemia. And any medical conditions that predispose to type 2 diabetes mellitus, such as polycystic ovarian syndrome. Cushing's disease and Wilson's disease are causes of type 2 diabetes that may also present with neuropsychiatric symptoms. So these are particularly important to be aware of in psychiatric patients, as they can often be missed, as these symptoms can be attributed to their psychiatric illness when really they may be because of a complication of their diabetes. When asking about the drug history, ask about the psychiatric medications that can predispose to type 2 diabetes mellitus, such as the antipsychotics and antidepressants that we have already discussed. Also, ask about the non-psychiatric drugs that can increase the risk of type 2 diabetes, including corticosteroids, thiazide diuretics, beta blockers, and statins. In the family history, it is useful to ask about any relatives with diabetes because of the hereditary component to diabetes. It's also important to identify a family history of premature cardiovascular disease to target other modifiable cardiovascular disease risk factors alongside glucose control. In the patient's social history, it is crucial to ask about their modifiable risk factors, such as their levels of physical activity, their dietary habits, any smoking, and alcohol use. When performing a diabetes-focused examination on psychiatric patients, it's important to note that the findings may be normal unless the patient presents with a hypoglycemic emergency or has advanced chronic disease, and which means they may present with damage to multiple organ systems. This may be seen in patients with severe mental illness presenting late to medical services, as they may be preoccupied with their symptoms of severe mental illness. The basic observations may reveal comorbid hypertension, so good to be aware of that. And on general inspection, note the patient's body habitus, evidence of dehydration, and presence of skin alterations typical of type 2 diabetes, such as acanthosis nigricans that we previously discussed. Lastly, perform cardiovascular and neurological examinations with fundoscopy to screen for complications of diabetes. Now, on to how we can investigate diabetes in psychiatric patients. The glucose concentrations that are defined as diagnostic are those above which an individual will be at high risk of developing microvascular complications. Diagnosing diabetes and pre-diabetes are particularly important in high-risk psychiatric patients, and we can do this with random or fasting plasma glucose, but psychiatric patients may not comply with fasting. Plasma glucose following oral glucose tolerance test, but this is often unfeasible in psychiatric patients. And measuring the HbA1c level, which is the simplest in psychiatric patients. However, keep in mind that this is inappropriate in patients with high red blood cell turnover, such as patients with sickle cell anemia or patients who are pregnant. One elevated glucose level is needed to confirm diabetes in symptomatic patients, whereas 2 elevated levels are needed to confirm diabetes in asymptomatic patients. We also need to perform investigations to screen for the diabetic complications and cardiovascular risk, such as blood pressure, cholesterol, renal function, and retinal screening. Now, onto the management. The overarching goals are to achieve normal glycemia and manage and prevent vascular complications. All patients should be educated and helped to modify their lifestyle, including help with their diet, physical activity, smoking, alcohol, the usual stuff. And for pharmacological management, there are no diabetic treatment algorithms specific for psychiatric populations, so we simply follow the guidelines used in the general population. And the choice of drug depends on the patient's tolerance for each drug and their risk of cardiovascular disease. Of course, there's a much more sophisticated treatment algorithm pathway, but in general, the first line option is metformin monotherapy, and the second line options usually involve the addition of either a dipeptidyl peptidase 4 inhibitor, thiazolidinedione, a sulfonylurea, or a sodium glucose cotransporter 2 inhibitor. As with all management choices, we have to balance the benefits of blood glucose reduction with the side effects. And over the next few slides, I've put tables that will help you weigh the benefits and risks of each drug. You can see the drug class, its mechanism of action, its risks and benefits, and its evidence base in severe mental illness. The glucagon-like peptide 1 receptor agonists are not one of the most common diabetic drugs, but they show promise in being particularly beneficial in psychiatric patients. And here is the last slide of this table. I haven't gone through the table in detail because that would take too long, but I wanted to include them so you can always come back to the recording and use these tables to prepare for any exams or any consolidation of knowledge that you might need to do. To round up the management of diabetes in psychiatric patients, here are some key things to consider for patients with severe mental illness. As obesity is common in severe mental illness, medications which can aid in weight loss or are neutral in terms of weight gain are preferable. For example, metformin, GLP-1RAs, SGLT2 inhibitors, and DPP-4 inhibitors. For patients with disorganized behavior or at risk of deliberate self-harm, medications which can result in hypoglycemia should be avoided, such as sulfonylureas and insulin, just as we mentioned when we discussed type 1 diabetes. And lastly, early use of metformin is advised in pre-diabetic patients on psychiatric treatment recognized at an increased risk of diabetes. So that rounds everything up. Thank you for your attention and engagement with this bite-sized teaching session. If you have any questions, please fire away now. Of course, my email address is on the screen there in case you want to ask anything else, and I'm happy to answer any questions, even beyond diabetes, if you want to know more about being an F1 or the Psych Fellowship scheme as well.
Hi, Manu. It was a really good presentation, actually. Thank you very much for that. I've got a question. If you want to go back to the previous slide.
This one.
Yeah, this one. So it says for the second point, when you say for patients with disorganized behavior or at risk of deliberate self-harm, medication which can result in hypoglycemia should be avoided. And I'm wondering if there is any reference for that, considering we have got patients actually who are type 1 diabetic actually, and they have got to be insulin. We've got a small population of patients who come here very often, who have got emotionally unstable personality disorder. They've also got type 1 diabetes. They come here either well, really in hypoglycemia, but mostly actually in DKA actually, because they stop taking their insulin. So when we say for patients with disorganized behavior or at risk of deliberate self-harm, medications which can result in hypoglycemia should be avoided. Is there any reference to that, or maybe it needs to be rephrased? Just wondering.
Yeah, absolutely. I definitely should have put when possible, because of course there are some times, especially in type 1 diabetics, where you can't really give anything else other than insulin. But when you say they come into hospital, I guess that would be a relatively safe environment to give them these, these types of drugs that can result in hypoglycemia if poorly controlled and poorly managed. So I guess in hospital, it's fine to do that when they're under the care of a care team who are going to be managing their medication administration. But when they're at home, of course, if there's no alternative to these drugs, there's not much we can do because the risks would outweigh the benefits there. But I guess when you can avoid them, we should, particularly in this high-risk population. And it's not just for any psych patient, to be fair. It is particularly in those at risk of deliberate self-harm, and those who, have behavior that may lend towards inappropriate use of their medication. But I completely understand what your point in that it's not always possible.
Yeah. Okay. So rather than saying should be avoided, we can say can be avoided. If I mean, okay.
Yeah, I'd say should be avoided when possible, because of course it's not always possible. Good. And I think that's the point you're alluding to there. And just in terms of a reference as well, I heavily relied on the Maudsley guidelines for physical health when constructing this presentation, and so that's where I found this piece of information. I'm sure within there will be a bit more detail and perhaps further references.
It does make sense, but it does make sense. It was only when it's the only option, then we look at the whether the benefit outweighs the risk. That's fine. Thank you.
Absolutely.
No more questions for me.
Great.
We've got a copy of that book at both sites, Hinchy Book and PCH, and I think there's one in the consultant's office as well.
Great.
But do we have any alternatives, or is it a case that we've got no other choice but do we have any current kind of research that we can give something that might be safer for that kind of client group?
No, it's a great question, because the alternatives here would reduce this risk of self-harm. I think what we could do is exhaust all other possible means of managing the diabetes, particularly with the lifestyle. But I understand that in type 1 diabetes, that's not so much possible. I guess delivering these drugs in safe conditions by a professional team would be a great way to do that, and also perhaps not giving too much insulin in one go. Perhaps a more modified release could be effective. But yeah, there's definitely a need for finding alternatives, because they are quite dangerous drugs when used inappropriately, and at the moment they are the key drug there. So I'm not sure. I'll open up to the floor there. Is there any alternative that we can offer here?
I had a long chat with an endocrinologist said actually there's no alternative. If one is type 1 diabetic, insulin is the answer. It's about having that. Yeah. So it's about us where possible mitigate the risk, but at the end of the day, it's about the responsibility of keeping one safe lies with the person themselves most of the time. So it's having that conversation. I have in the past tried to kind of advocate that by not giving them more than 2 hypoglycemics and all that. But the answer actually is, when the body is not producing insulin, having insulin is the only way forward.
Any other questions?
No, Manu, it was a really good effort, mate. Thank you very much.
Thank you. So I just if you don't mind, I would be hugely grateful if you wouldn't mind filling out the feedback form. You can scan the QR code, or I'll send you a link in the chat now. It just contains 7 questions, 5 of which are multiple choice, and it really helps with me developing as a teacher. So it would be hugely appreciated.
Will do. Will do.
Let me just post the link now. That's it.
Yeah, we all have captured it. Thank you very much, Manu. Thank you very much.
Thank you.